Good afternoon, nursing students. Our next chapter is Nutrition Assessment and Patient Care, which is Chapter 11. And it is important to note that you are nursing students and you are not studying biochemistry or dietetics. It's important to note throughout this chapter to look for symptoms of malnutrition, and to look for different biochemical values that is indicative of any deficiencies of malnutrition, as we'll see throughout this lecture today. On this slide, we look at patients that require a nutrition consult. So when you are positioned to work on a floor in the hospital, it's important to know who your RD is on that specific floor. You as nurses are in a great position to identify those at nutrition risk, including specific symptoms that should show that they warrant nutrition intervention. So to speak, like a red flag. Those I will review with you. The first one is decreased appetite, unintentional weight loss, elderly patients that have a medical history that warrants nutrition intervention, those that are malnourished, dehydrated, or with an advanced disease and based on the severity, moderate or severe. There is a term we use in healthcare, and it's called iatrogenic malnutrition. Up to 40% of patients admitted to the hospital are malnourished when they arrive and are admitted to the emergency room, or they experience what's called iatrogenic malnutrition during their stay. The term iatrogenic malnutrition is caused inadvertently by a procedure or treatment while the patient is in the hospital. For example, they remain NPO, they miss a meal or several meals because they're scheduled for fasting blood work or perhaps other diagnostic tests such as an MRI. So we note that it is important to monitor patients who are NPO or have clear or full liquid diets. Those will put them at risk for iatrogenic malnutrition as well. As nurses, it's important to identify symptoms of malnutrition, especially in hospitalized patients. Data from the Joint Commission demonstrates that poor nutritional status does a few things. It increases complications in the severity of the disease. It increases morbidity and mortality. Not only does there exist an increased risk of death, but it increases hospital stay and it affects the bottom line. So there's a higher cost of care. When you look at a patient entering the emergency room or being admitted to a specific hospital floor, identifying symptoms of malnutrition is important. The first area to look at is the skin. You'll see dry patches and eczema. Any type of wounds would result in poor wound healing with moderate malnutrition. If you look at the patient's hair, is it dry or brittle? Those are also signs of malnutrition. Looking at their fat or adipose tissue, we typically see a lack of muscle, a a lack of muscle, lack of subcutaneous fat, and in the muscle, you can tell that the muscle is wasting. For example, in like patients that are positive for HIV and then advancing to AIDS. Other signs of malnutrition are cardiac dysrhythmias, splenomegaly, and just general weakness or impaired coordination. Your ATI highlights those clinical symptoms that identify malnutrition, so I would definitely take a look at those. There is a four-prong approach to assess the nutrition needs of patients. We look at it through an acronym of ABCD. A standing for athropometrics, B biochemical data, C clinical, and D dietary assessment. So anthropometric measurements are techniques that measure height, weight, head circumference in children, and skin fold thickness. They're non-invasive techniques. We also do some calculations like the percentage of weight change, which is equal to the usual weight of the patient minus the actual weight divided by the usual weight of the patient times 100. We typically want data over time, so obtaining baseline and subsequent measures of the anthropometric measures over time are the most useful to assess nutrition changes. The best way to evaluate the weight of a hospitalized patient is at the same time every day after voiding. Patients that need to be weighed that are non-ambulatory, we have availability in wheelchairs or a bed scale, so that's extremely helpful. Other anthropometric measurements that we use are called MMT and HGS. So MMT stands for muscle manual testing, and HGS is hand grip strength. Both of them we use to determine muscle quality. Next component we look at is biochemical data. These are blood and urine lab tests, and they're useful for objective assessment of overall nutrition status. However, note that we compile many of the lab values and tests because no single test can assess short-term response to nutrition therapy. Let's look at and review some of the most important biochemical data for nutrition status. The first one is visceral protein stores, and that is further broken down into serum albumin and prealbumin. So visceral protein stores is basically how the nutrition therapy is being used. Is it adequate? Is it inadequate? And visceral protein stores is also a function of immunity. We also look at hemoglobin and vitamin D, which we'll go into a little bit more detail on the next slide. Visceral protein stores are proteins in internal organs and blood, not in muscle, and it's an excellent indicator of nutrition status and immune function. Visceral protein stores is estimated through serum albumin and prealbumin. Serum albumin in the blood is the best indicator of long-term nutrition changes because it has that long half-life. So if a patient is long-term, if they're in a skilled care center, maybe nursing home, looking at serum albumin is the best for long-term changes. Unfortunately, serum albumin can be skewed when dehydration is present. And that typically will indicate infection such as sepsis, burns, nephrotic syndrome, CHF, hepatic insufficiency, and protein malnutrition. So if those conditions or diseases are present, then the serum albumin levels are not going to be accurate. When we look at normal levels of serum albumin, it is the range of 3.5 to 5.0 grams per deciliter. We see a mild depletion between 3.0 and 3.4 grams per deciliter, moderate at 2.4 to 2.9 range, and then severe less than 2.4. So make sure that you definitely know and memorize those different levels. So in contrast, looking at prealbumin. Prealbumin is a better indicator of short-term nutrition status, secondary to its shorter half-life. The half-life is about, I think, 2 days. So it's a good indicator of inflammation, infection, and trauma on a short-term basis. So patients before surgery, I usually like to look for the prealbumin. Normal range is 15 to 36 milligrams per deciliter. We see a mild depletion in the prealbumin for the range of 10 to 15, moderate depletion of prealbumin 5 to 9, and then severe depletion at less than 5 milligrams per deciliter. So again, make sure that you know the ranges for serum albumin and prealbumin, and these are levels that are congruent with the ATI textbook. Our next set of biochemical markers are BUN and creatinine. Blood urea nitrogen. Normal range is 5 to 20 milligrams of urea nitrogen per deciliter. In terms of creatinine, we look at the range for males, 0.6 to 1.2. It's milligrams per deciliter. And females is 0.5 to 1.1 milligrams per deciliter. So those are the normal ranges. We typically know that BUN and creatinine are biochemical markers indicative of renal or kidney function. So those values are increased in renal disease. However, noting nutrition status, we tend to see decreases in BUN and creatinine in malnutrition. There are definitely different severities of nutritional risk. Who is at risk in terms of a moderate risk? And it would be those adults between the ages of 65 and 75. And then for children that are older than 5 years of age. Moderate risk albumin is 3 to 3.5 grams per deciliter. High risk are those adults that are ages 75 and older, and children that are younger than 5 years of age. We also have other parameters, which include 5% weight loss in a month or 10% weight loss in 6 months. Albumin levels are less than or equal to 3. And in children, when we look at the growth charts for length for height, and they're less than 5th percentile, or weight for height also being failure to thrive, less than 5th percentile. In high risk, we also see patients that are not fed orally, so they're either MPO, or they're on clear liquids for 3 days or longer, or they're fed via enteral tube feedings or TPN. As part of this chapter, we will look at drug-nutrient interactions. As nurses, it's critical for you to review your patient's concomitant medications and certain drugs that have an effect on food or nutrients. Same goes with dietary supplements, which include vitamins, minerals, and herbs. Many patients believe that dietary supplements are harmless. My medical opinion is that dietary supplements are more dangerous because they do not undergo clinical trials and they're not regulated by the FDA. Drug-nutrient interactions can affect the drug's efficacy, so it's not as effective. It can decrease or increase absorption, could cause nutrition deficiencies, and have its effect on metabolism or provoke a toxic reaction. What I did on the next several slides is I took some of the more common medications and looked at the nutrition and the nutrient drug interactions. Also important for exam 3 and also for nutrition ATI. This is some of the medication from table 11.6 in your textbook. The first one is anti-ulcer agents, so ranitidine, cimetidine. Anti-ulcer agents will decrease vitamin B6 absorption. Next is the anticonvulsants like phenobarbital or phenytoin. Anticonvulsants will decrease the vitamins folate, vitamin D, and vitamin K. Antidepressants. Now, this specific antidepressant would be lithium carbonate, used for schizophrenia. Patients complain of dry mouth, they feel nauseated, some vomit, anorexia, or it could go the other way. I've seen patients on lithium carbonate. It's a very old drug. Either they have a lack of appetite or it causes them to have an increased appetite. So what's important with the dry mouth is to recommend that they increase fluids. Our next medication is antihyperlipidemics. Those include cholestyramine and cholestyramine. And these two medications, when I worked in clinical research, I tested those. Those are not statins. So they're in powder formulation that definitely affect fat-soluble vitamins because the medication is absorbed in the liver. It affects B vitamins such as folate, vitamin B6, vitamin B12, as well as iron. With corticosteroids, those include prednisone and hydrocortisone. Steroids will decrease the absorption of protein, potassium, calcium, magnesium, and zinc, so quite a few minerals, and then vitamin C and B6. We have a class of drugs for hypertension called loop diuretics. Those are furosemide. And the nutrients that are affected here would be the minerals, decreased absorption of potassium, calcium, magnesium, zinc, sodium, and chloride. This next slide is a summary of your textbook table 11.8. We look at antibiotics such as Cipro, ciprofloxacin. Dairy products will decrease the absorption of this particular antibiotic. And if dairy products are consumed with ciprofloxacin, then it also reduces its effectiveness or efficacy. A well-known class of drugs are the anticoagulants, so warfarin, also known as Coumadin. Patients should be instructed to limit the amount of vitamin K rich foods in their diet. So broccoli, spinach, kale, turnip greens, cauliflower, and Brussels sprouts. So if they consume vitamin K, it's not actually just stopping all of vitamin K. As long as they can keep a consistent amount of these types of vitamin K rich foods in their diet, that is okay. So if they consume them once a week, they can continue, but it has to be consistent. Next are the antihypertensives. So those would be your beta blockers, verapamil. It's important to avoid any type of licorice, so natural licorice, and tyramine rich foods. Antidepressants, so these are your MAOIs, the monoamine oxidase inhibitors. Those are called phenelzine, and the one that was actually on the ATI, which is very hard to pronounce, and typically docs don't prescribe it, but trancypramine. It's important to avoid any type of foods that contain tyramine. So there's a very long list, and that again comes from table 11.8 in your textbook. So any patient on MAOIs, you're instructing them to avoid beer, red wine, any semi-soft cheeses, so Camembert, aged cheeses, blue cheeses, those are all those soft, semi-soft cheeses. Also, you want to avoid aged cheese, blue cheese, brie cheese, mozzarella and Parmesan cheese, yogurt, sour cream. Also, any type of game meat such as venison, caviar, dried fish, yeast, and the list goes on. Any type of fermented foods. So kimchi, which is a fermented Korean delicacy, and sauerkraut, those are to be avoided. Any type of fish or shrimp sauce, soy sauce, miso soup, which is very common in Israel. Those who practice the Jewish laws consume miso soup, fava beans, also any type of beef, liver, chicken, cured meat such as sausage, prosciutto, and salami. So again, I would screenshot this. It's definitely ATI material. The last topic in chapter 11 I want to touch on is tube feedings and drug-nutrient interactions. We will be getting into position of enteral tube feedings and different formularies. But just to review drug-nutrient interactions, it's important that if your patient is on an enteral tube feedings and has specific medications that need to be administered, you want to use liquid formularies whenever possible. You can contact the pharmacy to determine what is on their formulary. If they do not have it available or the pharmaceutical company doesn't make liquid formulary, then if it's in tablet formulary, tablets can be crushed. If they are in capsule formulary, then we typically will recommend that you open the capsule in half and the contents of the medication can be mixed with the tube feeding formula. You always want to flush the enteral tube feeding with warm water, 15 to 30 mLs. If you're administering medication, you want to flush the tubing with 30 mLs before and after administering medication. This is kind of like off the table, but if a tube feeding becomes occluded, the best way I have found to unclog a tube feeding is to use Coke, and it should be at room temperature, so there's not a lot of carbonation, but it works like a charm. Okay, that's all I have for you for chapter 11, and I will upload this to Canvas. Thank you.